You mentioned something very interesting, Doc, when you're discussing about how obesity and your weight can actually contribute to you getting diabetes. Woo-wee. And then you mentioned something that has been a hot topic in this country, Ozempic. What was the Ozempic? Kuna Mujaro, and I know you know other things.
So, yeah,
Yes.
all
You
those.
mentioned how
Those
they
are
can
the ones that are hot cake, but there are others, by the way. It's just that
of
hizo ndio
course.
zilikuja zikachukua the world by storm. The whole world,
Yes.
not just there. Hata hapa, every week I get
Eh,
somebody asking me, daktari, please, uniandikie kwa tu ile.
eh.
Niandikie.
Hebu sasa tuambie
Mm.
tuchukue ama tusichukue ama how do we go about it?
Weight loss. It's always been a big topic. And I guess that's why when Ozempic came, the discussion even moved from its intended issue, which was diabetes. It reminds me of Viagra. You know, Viagra was
Yeah.
for pulmonary hypertension. Like
Yes.
people were just they were just in a trial for
Mm.
pulmonary hypertension. And then they went and told the investigators, hiyo dawa mlitupea lakini
Mm.
doing some things. And then suddenly, because the money is in that other thing, that's where it went.
Yes.
And so Ozempic gives me the same vibes because it was initially just meant to be a diabetes medicine, and now things just changed.
If there were no patients, doc, we would not be doctors. You'd be a doctor of what? You know, if there were no sick people, there were no people with diabetes, hypertension, or the things that you love looking into, what would be doctors of? We need to listen to our clients and what they need, and not just push things down their throat. I've said it is like this, it is like that. One of the biggest problems we are now experiencing is behavioral change, where there's this policy we have as Kenyans where we say, what you don't know doesn't kill you. Why do I want to go and get
Yes.
checked or screened?
Hey,
And then
alafu
there's
ni
something
stress.
that I
Eh,
what were people, and
that is such.
that's one of the reasons why people don't go for screening,
Mm,
because they're like, hii inaangalia nini? Inaangalia cancer fulani. Alafu mkipata mtafanya nini? And then now you explain, and then they're like, ni sawa tu, nitakuja siku ingine.
siku
That
ingine,
person will
which
not
never
show
comes,
up.
which doesn't
Yes.
sound.
But in the light of also making them not feel like it's always their fault, despite our behavior issues, sometimes I think our failed healthcare system also makes people scared, because people are like, you'll be found with something, you have no finances to deal with it, niitishe harambee, niitishe mtoto, all those things to be able to support
Yeah.
your health, because you can't afford. And you know, these days that's how people are actually surviving. We have ladies who are taking steroids. And do you know how many pills they are taking in a day? About 18, they mentioned 18 to 21 pills in a day. Do you know it is for what reason? So that they can
Like,
get the, what is that face called?
oh, the cushingoid nini face. The
Yes.
nini. Oh my
Yes.
gosh. Are you
They can get
serious?
the face, they can plump up, they can,
Are you
become
serious?
rounder and all that. They can have the hump, because it is being
They
looked
want
at
the ham. Who
the
wants the
beautiful,
ham?
like you look beautifuler and all that. And they are also adding now the creams on top.
To
So
lighten them.
now, exactly, you're round and light.
Oh,
Imagine the kind of complications that they're coming up with. Do you type 1, do you type 2, do you want all those things? Something you didn't have, now you have it. But all in the name of looking beautiful and satisfying societal norms and standards at the expense of your health. Diabetes type. What did I hear recently?
up to
Type
type
4.
5.
Yes.
Type 3.
I need that class. Hey, hey, hey. Abita will tell us what are those things. Since we left it at type 1 for insulin, type 2 oral medicine. Because, I actually believe a population that is informed, aware, and knowledgeable is a population that is able to make changes, is a population that is able to ask questions, is a
Yeah.
population that is able to demand more for better healthcare systems. Today we'll be having a guest on our podcast. Her name is Dr. Hilda Nabiswa. She is a renowned endocrinologist specializing in diabetes. So she's an experienced physician with a demonstrated history of working in the hospital and healthcare industry, strong healthcare services, professional skills in healthcare consulting, epidemiology, medicine, prevention, and infectious diseases. She's currently a diabetologist with a passion for patient education and empowering clinicians to improve treatment to people living with diabetes, hypertension, and other chronic non communicable diseases. And she does this in Canada. Daktari, you are welcome.
First of all, thank you so much, Jackie. I guess K means Jacqueline, right? Is that your... No?
No, it's
What does
actually
J mean?
my yes, no. It means
Oh,
it's my first daughter's name,
uh-huh.
and it is based on the concept of rebirth
Oh
because she
boy.
was yes, she was the reason as to why I started this.
I see. Okay,
Yes.
interesting. Fine. So, thank you so much, Dr. Jackie, for inviting me to your platform. And it's an honor to be here. And I like the vision that you have of wanting patients to take back their power when it comes to their self-care, which is pretty much what you're saying, because many years of being in patient care has shown that a lot of them put faith in the system, but sometimes the system might not work as well. It's very important for them to take back that power. So it's very important for that to happen. I worked in Kenya as an internal medicine physician. And then I also did my diabetes and endocrinology while in Kenya. And then after that, I moved to Canada, where I am still practicing diabetes, endocrinology, internal medicine. And I'm enjoying it because it's what I like and it's what I love. I have been a doctor for I think 14 years now, and I've really loved the journey. When it comes to the experience in the diabetes field, I have seen all spectrums. Like I've seen the whole shebang, if you want to call it that, because I have been in resource poor settings, resource rich settings, and being able to navigate through all that, and then learning that at the end of the day, the patients are the same. It doesn't matter which country they're in, the resources they have. They all want to be heard. They all want to be understood. They all want somebody who will give them the tools to walk through their journey, their disease process, and help them understand how to navigate the system better. So that's my calling, is to help patients understand themselves and their chronic disease better and know that they have the tools within themselves, and also help them with the tools and resources that I have to make their journey more manageable. Yeah.
Ah, amazing, amazing, Doc. How is it for healthcare workers to work in different settings from where they are
Mm.
born? Because I can only imagine a culture shock and change in how we usually practice. Here we're a bit mellow with each other. You make a mistake and things move on, and our clients are also not very too harsh with us. So I think that
Mm.
is something we can have a convo on
Yeah.
how we phrase it, but how healthcare in the diaspora or something.
Yeah, that would be a good
Yeah,
topic. That would be a good
yeah.
topic. Yeah.
Because in the light of how also doctors are also lacking jobs, especially in the Kenyan context, or they're also not being, you can shed light on how do we go about doing this in a different country. Yeah.
Country.
Mm.
That's true.
You mentioned something on how clients love to be heard.
Mm.
And I totally believe that because for me to go into the space of integrative and functional medicine, I was once a client.
Mhm.
And I walk into the space of a doctor's office and I'm talking, but I'm like, you're not hearing me. You're
Yeah.
telling me to see a mental health specialist, or you're telling me to go see you think that I have an infection or something of the sort, and that's not the case.
Mm.
And I used to feel bad because in my head I'd ask myself, if this is me, a healthcare worker, not being understood or heard,
Mm.
What about a client? Is this how they usually experience us?
Mm-hmm.
And I remember I was going through something called for us it would be IBS. For the common layman would be stomach ulcers, what people know H. pylori, all that stuff. So I had it for about 4 years, and I ended up having. I was very small. I was about a size 4'6", which is a very small girl. So I was about 45 kgs. And I was on a very limited diet. I'm not eating this, I'm not eating that. And the root cause of all these things happening was because of my lifestyle. I was stressed a lot because I remember it started just during internship. And you know how internship happens. You're always on call, you've been on shift for 48 hours, and you're not stopping. So I got sick. And for 4 good years, I was always taking, omeprazole and all these Malox, and diet was restricted. So of course, I lost a lot of weight. So after the 4 years, I was like, at some point, Jackie, I don't think you want to live like this for the rest of your life. You're always out here prescribing for clients. Take this, take this, take this. And sometimes there are so many, you don't even look at their face, you don't even know who they are or anything like that. So I was like, Jackie, no, you can't live like this for the rest of your life, where you're on a restricted diet of rice, cabbage, and boiled chicken, and
Mm.
you're not enjoying anything else. And that is how I quit my government job and decided I need to go figure out what is wrong with my stomach and what's going on. And so that's how I ended up in this healthcare space of looking at clients from a holistic approach. And there's nothing as fulfilling as that. Despite how long you may follow someone, at some point they follow. So, cutting story short, I am now doing very well. I eat healthily. I stopped being a size 4. Now I am a size 10. This is many years later on, but that's what got me into the practice of looking at clients holistically.
Mm.
So I don't know, from your perspective, Doc, what made you decide now I'm going this route?
Mine was quite interesting. First of all, I must say, I love your story. I love your story, Jackie, because for you to fully understand a process, you have to somehow be part of it. You cannot be removed from it and still expect yourself to understand what's going on. So I'm really glad that you were in the process and you realized that, hey, there's something here that I need to fix. So you found your passion that way, and congratulations. Mine is I actually did internal medicine. Let's start with the internal medicine part. I did it
Okay.
because I did not want to be woken up at night to do a surgery. I didn't want to deal with children. Okay, so it was like elimination, elimination. And I know I'm very good at doing exams and reading and stuff. So I was like, I'll internal medicine. And I went into it.
Yes.
I actually did it in Aga Khan.
Mhm.
And after that, there were these scholarships being given. So one of my mentors has done diabetes and endocrinology, and he kind of mentored me into that path. But at the same time, I have had polycystic ovarian syndrome since like
Oh.
forever. And I wanted to understand myself better. So that's why I went into endocrinology and diabetes, because
Mhm.
I myself have a problem that is related to the endocrinology side. So it's pretty much a lot like yours. But the funny thing is that I realize now that I was still kind of in denial. I never truly treated myself for that. Like I never took it seriously. Even though I knew I had PCOS, I only started taking it seriously this year and taking medications and being like, okay, this is it. These are the changes I have to make in my life. And the difference has just been incredible. And that's why I understand it when patients find it difficult to make certain changes in their lives, or because sometimes you're just in denial. It's not a perfect journey as a patient. It's not a perfect situation. It might take you years to get where you want to get. And personally, for me, I'm finally at that point where I can say I think I am finally getting the PCOS under control all these years later, even though I am somebody who's specialized in that field and I treat people in that field. But it's always been a journey of trying to self improve and getting better. So yeah, it's also personal for me as well.
Ah, nice. I think flowers, if we had those things that usually come on Zoom, we would have put the flowers everywhere. The concept
Oh,
of us talking
yay.
about that.
I think you can see that for me.
Ah, yes, yes. I love the concept of how we are looking at health as a journey because most of us, and even when we're in school, we are taught about how we take a pill for every ill. Like it's, I have a headache, I have a maramoja. I have a stomachache, I take this. I have this, I take this. So there is no journey of actually finding out what is going on and
Mhm.
when did it start to the in between to the how it continues to when it stops. We consider our health as a fix it, and most people look at doctors as fixers. Like
Mm.
if they come and you're not fixing their issue within, or they've not felt an improvement within, I don't know, 3 months of say, ah, they're like, "Hapana. I need a
Ah, we are
second,
fine.
third, fifth.
Mm.
Yeah, we are doing immediate afana. I need another opinion. I need, and sometimes people don't understand. Maybe your healing journey and your healing process is just slowly by slowly.
Mm.
Now, but is that also the work, let me call it work or homework that your doctor gives you, most of us don't end up doing it. You come back and you say, the things you told me to do, I have not done. So when you find you sit with the client for that 1 hour, for that 30 minutes, is when you discover hata hakuanza kitu ndio ulimwambia. They already, but they are complaining that they've not seen any positive change. So it is a health journey. And which makes me wonder, how is health between Kenya, Canada? Like how our health systems, I am sure our health
Uh,
systems are here.
now, Jackie, I think that's just a topic for another day because sijui nianzie wapi, sijui
Eh,
nianzie wapi. All I can say is, unfortunately, Kenyans, we are on our own. That's just the thing I can say. Like, what in a nutshell, in Kenya,
yeah.
if you don't have money, you're on your own. Period. That's it. That's just it. If you don't have a good insurance, if you don't know somebody who knows somebody who can get you to India or whatever, you're done. And it really breaks my heart because I have worked in Turkana. I have worked, like me. I'm talking because I feel like I can talk because I have worked in the public sector. I've worked in the
Mhm.
faith-based sector. I've worked in the government, in the private sector in Kenya. So I know deeply how each and every part of the system works there.
Yeah.
And the truth is, if you don't have money, pole in Kenya. That's just it. Whereas here, I airlift patients, airlift for free, Jackie. Right now, you
What?
attack, yeah, I approve. You get airlifted, you go get your treatment, pay 0 shillings, leave the hospital, move on with life. They don't care if you're a street child, if you are some farmer from the village, or the president or the prime minister, you get the same care. That now you
What?
tell me, you seeing the difference? Like,
That's
it's
an
nice to
extreme
say.
difference.
I cannot. When I first came here and patients were being discharged from ICU, and I'm not seeing anybody come to cry to me or come to ask for money, michango, or whatever, it was a culture shock by itself. I was like, how do you just walk out of ICU? Like, oh, you're done. Go take your meds and you're done. I was like, it was a shock. But
Mm.
yeah, we have to improve the systems in Kenya. We have to get better leaders. Like, it's a matter of urgency. We can't keep on just saying, oh, the reason why you're on your own is because the government is not working for you despite you paying the taxes, which means we need to get a better leadership. That's it. It's a leadership problem, in my opinion.
No, I don't think it's just in your opinion. We all know we have a leadership problem, and we just keep singing the same song
Yeah.
over and over and over again, and just keep shifting names from one name to another, calling it something else, but then the underlying problem is still the
It's
same.
the same.
And
It's
it
the
just,
same.
and unfortunately, it's just going to get worse because
Mm.
disease is not stagnating and saying, okay, you guys don't have a healthcare system, you guys don't have proper insurance, you guys don't have money. So let
So
me
let
first
me
take
let me Have you seen the slide, Jackie, for the growth of diabetes, like projected growth in different continents? I wish I had that slide. The projected growth of diabetes in America or in Canada, where I am, is 24% by 2045, which is not bad.
Yeah,
The
it's not so
projected
bad.
growth of diabetes in Africa is 183%. 183%.
What?
Yes. Na saa hizo, there's no 183% increase in cath labs, in dialysis units, we are not ready to deal with the complications. And that's why, Jackie, we have to preach control. We have to preach preventative. Do
Yeah,
as much as you can what is in your control, because if you leave it at the system will take care of, there's no system to take care of it. Whatever you can take care of yourself, do as much as you can. That's why I like your approach of telling the patient, you know what, the power is in your hands. For most cases, of course, there are some cases which are unique. You have patients, for example, who have familial hypercholesterolemia, their cholesterols are through the roof, they get atherosclerosis. There's always outliers, but for the majority of patients who have type 2 diabetes or hypertension, as long
yeah,
as they're able to get the control, they will at least avoid the complications, majority of them. So
that's
that's why
right.
we keep on preaching that prevention and then screening for complications early, because we don't have the capacity to deal with the complications the way here in Canada they would. So yeah,
You see that statement you made? I think it should just put people in shock mode. We do not have the capacity to
we
deal with
don't,
complications.
we
Full
don't,
stop. Yes.
we don't. It's a joke. It's a serious joke. And then I think them when you come out here and you see the way they deal with complications. Let me tell
Mm-hmm.
you, even like my patients who have diabetes, when I look
Yeah.
at their past medical history of lung cancer in 2005, history of breast cancer 2010, history of whatever. And I'm not saying that we don't have, like, what I'm trying to say is I didn't see as many people who had a history of cancer in Kenya because most of them die. Most of them die. Like, how many patients have you clocked and you're like, oh, you had a lung cancer in 2010, pneumonectomy, now you're cancer free. Ah, okay.
Yeah.
How many exactly? How many? That by itself was a shocker to me because I realized that we are living very different lives.
Yeah.
The difference is so stark. And again, it
Mhm.
goes back to what we can get in our country. In Kenya, we still have a lot of systems to set up. Our cancer is diagnosed too late. People don't like to go for screening, or maybe they don't have access to screening. There are many things that just make it harder, I guess, for people to be diagnosed earlier in the third world countries, not just Kenya, in literally all
Yeah.
the countries. Yeah.
And in light of what you're saying, I think one of the biggest problems we are now experiencing is behavioral change,
Mm.
where there's this policy we have as Kenyans where we say, what you don't know doesn't kill you. Why do I want to go and get
Yes.
checked or screened?
Hey,
And then
alafu
they
ni
introduce something that
stress.
I
Eh,
what will happen? And
that is so
that's what, one of the reasons why people don't go for screening,
true.
because they're like, "Hii inaangalia nini? Inaangalia cancer fulani. Alafu mkipata mtafanya nini?" And then now you explain. Then they're like, ni sawa tu, nitakuja siku ingine.
Siku
That
ingine,
person does
which
not
never
come.
comes, which doesn't
Yes.
come.
But in the light of also making them not feel like it's always their fault, despite our behavior issues, sometimes I think our failed healthcare system also makes people scared because people are like, you'll be found with something, you have no finances to deal with it,
Mm,
niitishe harambee, niitishe mchango, all those things to be able to support
yeah.
your health because you can't afford. And you know, these days, that's how people are actually surviving.
Mm,
Your healthcare system is free. Whereas
mm,
here you have our healthcare system is basically out of pocket. We may see here how we have SHIFSHA, NHIF, etc., etc. It's still out of pocket. We pay a lot of money. Even for that private insurance, you put a lot of premium into it for you to be able
mm,
to be taken care of. And mind you, if you get a chronic condition or you're predisposed to one, your premiums now change. I've always wondered why not go into the spectrum of the space of preventative healthcare and wellness. And maybe we even give people coupons or just something, incentives to make them actually move towards the preventative style. So you're told for every wellness check that you do and they don't find anything, maybe we'll pay your rent for like 1 month. Okay, I'm just joking, but it's an incentive that pushes you towards taking care of your health better. Because
Yeah.
there's a story, and other than behavioral change in our healthcare system, there's a story I was listening to yesterday, and it is in the context of Mandela. And now this brings in the concept of where you are versed in diabetes, hypertension, chronic diseases. So in Northeastern, we have ladies who are taking steroids. And do you know how many pills they are taking in a day? About 18, they mentioned 18 to 21 pills in a day. Do you know it is for what reason? So that they can
Like,
get what is that face called?
oh, the Cushingoid Nini face. The
Yes,
Nini. Oh my
yes.
gosh. Are you
They can get
serious?
the face, they can plump up, they can,
Are you
become
serious?
rounder and all that. They can have the hump because it is being
They
looked
want the
at
hump. Who
the
wants the
beautiful,
hump?
like you look beautifuler and all that. And they are also adding now the creams on top.
To
So
lighten them.
now, exactly, you're round and lighter.
Oh,
Imagine the kind of complications that they're coming up with. That was it was a podcast I was listening to of some doctors who are in Northeastern who've been doing a certain podcast, which is very interesting. And now they were discussing about how that doing of the steroids is coming up with now complications of diabetes, hypertension,
yeah.
you name it.
Yeah.
You know,
Even adrenal insufficiency. Yeah. Because at some point they might not take steroids for some time and boom, your adrenals just they go to just
exactly.
yeah.
And you
Wow.
can imagine the kind of work it will be to even wean off that person out of 18 to 21.
I cannot even. That is such a huge dose. Oh my goodness.
Exactly. And now imagine, now that's a new problem that we did not have that has started developing on that part of the country, right? And you
Wow.
see now people don't know. Sometimes as human beings, we don't know. Even as the healthcare worker, you'll be knowing if I take this route, this is wrong, this is correct, this is okay, this is bad. They don't know. Them, they're looking at it from that perspective. But then they end up complicated and in the hospital. Now all these things come up. Do you type 1, do you type 2, do you what all those things? Something you didn't have, now you have it. But all in the name of looking beautiful and satisfying societal norms and standards at the expense of your health. Yeah.
Wow.
This is now you see every single day. So you're saying our healthcare system can just stop. Every single day we have something new that has to be discussed. Now this is a whole new fresh,
I,
right?
like I can't even believe it.
Exactly. Yeah. And in as we're
But
discussing, yeah, yes, no.
that means that there's a pharmacy somewhere that knows better, but is just dishing out these because they're not getting these medications from nowhere, right? So there's a probably either a pharmacist somewhere or a doctor somewhere giving out these medications. They're not just
Exactly.
getting them from nowhere, which again means there's a problem with the healthcare system because who is this who is doing this?
Yes.
Lack of oversight.
Yeah. These days you find how many chemists and all these things are run by people who didn't even go to any form of
Yeah,
school.
yeah. Or
Amefungwa hiyo kitu
parallel
kama
imports.
biashara.
Yeah. Or parallel imports. People are just bringing, some people bring drugs straight from street. They smuggle them in. So
Yes.
they can't be accountable to really anyone because they're just doing their own thing. Nobody even knows they have the drugs. Oh my goodness, that's just wrong. Anyway,
I know.
okay.
And we've had clients who come to us. So, example, those ladies, I know they start trickling down into Nairobi.
Mm,
So they are now specialists in those areas. So they will come, you've checked their sugars, you've checked their pressures, things like that.
mm.
I've recently heard of something called, and now this is you educating me because I think, diabetes type. What did I hear recently?
Up to
Type
type
4.
5.
Yes. And
Type
this one,
3,
I
type
need a
4.
class. I think I'll tell us what are those things. We like to touch type 1 for insulin, type 2 Oral.
Yeah, so let's go through the initial ones. Yeah, so type 1 diabetes is where you don't have insulin, right? Like you don't make insulin in your system, and because you don't make insulin, then whatever carbohydrates you take or whatever breaks down into sugar in the body cannot be utilized, because insulin is the thing that would bring your sugar from the extracellular space or from outside in the bloodstream into the cells to be used for energy. So that's type 1, where you don't have anything. Type 2 is where you have resistance, and that's where obesity comes in, PCOS comes in, some just genetic factors also come in with type 2. And insulin resistance, basically meaning that there is a lot of insulin in the system, but it's not being utilized the way it should. Okay. Now, type
Okay.
3 diabetes is where the problem is from mostly the pancreas, like type 3C diabetes. Yeah. So it's mostly from the pancreas, like anybody who had pancreatitis, pancreatic cyst, pancreatic cancer, anything that would intrinsically destroy the cells of the pancreas, because the pancreas is where insulin comes from. So, in a way, it is related to type 1 because you end up not having enough insulin. It's just that the reason for you not having enough insulin is from the pancreas itself being damaged, as opposed to type 1, where it's autoimmune destruction most of the time.
Yeah.
So,
Mhm.
that's the difference. And then type 4 is like what my grandfather has, which is diabetes in older people. So you find people who've lived all their lives. Like my grandfather is now 92, turning
Mhm.
93. God bless his soul. And he got diabetes at 82, which is like
Mhm.
long. Like, yeah, like that's he lived a long life. So basically his pancreas just got tired, but he's still just on metformin. Like he's not on insulin. But any of these people who get diabetes when they're very, very old, most of the time it's just linked to insulin resistance. But in older lean adults, and it's not people who are very overweight. Like my grandfather is a perfect case of type 4 because he's lean, he got diabetes at 82. Then now type 5, which is very interesting because we've been seeing, like I remember even when I was in Kenya, and I would see people coming in with diabetes that was not type 1 because they were not going into DKA,
Mhm.
but then they were skinny, so it was not type 2, but they were very poor. Like, so you
Mm.
could tell that they have not been nourished well in their lives. Like, you get what I mean? But you
Yes.
can tell this is not type 1 because they are probably in their 40s. So it's like it's not giving type 1. It's not giving
Mhm.
lad because there's no
Mhm.
family history. It's just them. So right now, when I think about it, I think it's actually important because type 5 diabetes is people who basically it's like your pancreas did not get enough nutrition growing up.
Mhm.
So because it didn't get enough nutrition, mostly it's because of malnutrition. That's why it's mostly in poorer places in Kenya or in the third world, I would say. But that said, what we consider the diet for the poor in Africa is actually the diet for the rich here, because a lot of them, the people here can't afford organic foods, but a lot of the people in shags were eating organic mboga, organic sindio. They eat mboga ya yenye nini kwa shamba, mahindi wametengeneza kwa shamba. So a lot of that food is organic, but there are some people who just were not getting enough of that food anyway. Now those are the ones we are talking
Oh,
about.
excuse me.
Saying, I'm not saying that the kind of diet that they were getting was bad. It's just people who never had good access to food, to healthy food when they were younger. They get the chronic undernutrition during their early life. Then they get type 5 diabetes. Yeah.
Ah, okay. I'm
Mm.
telling you, every day in the healthcare, we are always learning
Yeah.
something new. The day I came across type 3, 4, and 5, I was like, oh,
What's
should
going
be good
on?
for them. Like, develop a type 6, even though they have type 6, you know. But anyway, um,
But talking about types of
and that's
diabetes,
it.
talking about types of
Mm.
diabetes, there's a type of diabetes called LADA. And LADA is latent autoimmune diabetes of the adult. And these people get on insulin very quickly. They also look a bit lean, but it's like a type 1 of older people. And they initially can respond to orals. That's the difference between them and just proper type 1s, is that they can actually initially respond to orals, and then at some point they just don't, and then they have to be on insulin. And I realize even here that people hardly check those people for antibodies. Even here, because checking for antibodies is free, I have diagnosed quite a number of people in their 60s, in their 50s with LADA. They never knew. They always thought they were type 2. Always thought they were type 2. So it's very important to do those auto antibodies for any insulin requiring person, especially when they're an adult. Yeah, because LADA is more common than we think it is.
That's interesting. What is going through my mind is the fact that I am sure amongst all of us, or rather the people who interact with the client as the first ones, if you ask them about any other forms of diabetes other than type 1 and type 2, very rarely will someone tell you that they know anything else. And I think now we've gotten a podcast, number 4. This is also something that needs to be expounded also from a healthcare perspective, as well as from just our clients, the population, because I actually believe a population that is informed, aware, and knowledgeable is a population that is able to make changes, is a population that is able to ask questions, is a
Yeah.
population that is able to demand more for better healthcare systems.
Yeah.
Because I'm just trying to imagine, by the way, God bless your grandpa at 92. And I'm imagining he's in a framework of where you can be able to help him out with what he needs. An elderly population in this Kenyan context of poor setting. I know this Kenyan context, we're dealing East Africa, and they cannot be able to afford whatever it is. Most of the 92 years old have been sent their grandchildren to deal with, or
Yeah.
income. They
Yeah.
have to fend for their food. We forget them. They are in homes. So
Mm.
there are a population that has been isolated in a certain sector. So they also need to be able, and this is why we keep having this conversation of preventative medicine, because as much as genetics has a role to play, a very big percentage now is all these other things that we are really joking around with. And it really hurts my feelings how we really play around with our population and our environment to the point where it's fine. We can have more foods. It's fine. We can throw all the pesticides and the herbicides and all the chemical-based things that are used to grow our crops around. Why? Because they're giving us food faster. Our output is quote unquote higher and our yields are higher, but at the expense of our population. Because now you find guys develop these conditions. And most of them start at a point where you actually don't know, because we call it a stage 0, where by the time you're getting diagnosed, that thing has been ailing you for the last 10, 15 years before a doctor actually decided and checked your sugars and found it to be very high, or your blood pressure was high, something like that. And the fact that we do not even entertain the thought of dealing with such things, and we just pour things out into our population, is very disheartening. And but the good thing, I usually say there's a positive to every negative, is the fact that people are now woke, because people are now reading a lot more, and you'll find someone will actually come and ask you, lakini in my whole family, there's no history of
Diabetes.
so try to tell me that I have diabetes. Number two, I've been exercising, I've been doing this, I've been doing that. So what exactly is going on with my system? And now that is where you have to dig deeper. And even from a holistic and a functional medicine perspective, this is where we speak on, other than genetics, what is this other thing that is causing a problem? So those things we are mentioning, things like heavy metals, things like chemicals, things like herbicides, pesticides. Do you know even the things we apply on our bodies actually have an impact? So these things we use roll-on, perfume, uh, these things we use fragrances to improve how our clothes smell after we
Even
wash
Nini,
them.
even chemical. So you remember the chemicals were associated with fibroids. Yeah.
Yes, yes. So all those things end up affecting our health. And people, what I love is the fact that human beings are becoming woke to these situations, and they're like, no, can I get an alternative? And that's why you've noticed a lot of, especially the Kenyan market, because I'll speak of somewhere where I have worked in. You've noticed a lot of Kenyan-made brands that are making this shea butter, like natural things for our own bodies, our natural roll-ons, our natural perfumes. There are very many people who have even gone into the space of herbal medicine where they're now looking into what can people eat, you know, because I remember the time we used to go to Ushanko, and my bro always used to get some rashes after he had proteins. And every single December, because we always used to go in December, they would boil some leaves. I don't know what it was. Now I suspect it was stinging nettle. They would boil some herbs, and then akipewa akunywe. Within a day or two, those things are
They're gone. Wow.
literally, no.
You know, that's one of the problems I have with the current health system, or the fact that we we use Western medicine, yes, and a lot of it has been researched, and we know the side effects and whatnot, and that makes it good. But that shouldn't come at an expense of losing our own medications. You know, my dad told me of a story where when he was young, his mother had leprosy, which right now is treated for how many months? You know, the
Yes,
way
yes,
leprosy treated. But his mother went to and my father is a doctor. So he knows immediately he learned about leprosy when he was older. He immediately
yeah.
remembered my mother had leprosy. So
Mhm.
the mother went to a traditional healer, got some concoction. I don't know what it was because, of course, the healer died and now that thing all died with him. So they don't know what it was.
Yes,
But
yes,
he was treated of leprosy.
yes,
And looking at all the cancer medications, where do they come from? Fungi, natural elements. Look at China, malaria, artemisinin, the bark of a tree, you know,
yes,
things like that. So I think we have a lot more to do as Africans to try and bring our traditional medications and not give up on them so easily. Like if anything, we should just do more research and find out which compounds are these in stinging nettle
yes,
that are working, and then now make them into a proper medication, because that's exactly what these people did with cancer medications. Those doxycyclines and taxanes and all that, they were all just fungi. And so, yeah, we need to do more research as
yeah.
Africa, but we don't because we are busy. We are still on survival mode. That's what I think.
We are still on survival mode, but I think if we continue as a population to, you know, focus more on what we want and demand it from, at some point,
Yeah.
the healthcare system will just be like, okay, fine, what are these things these people need? They need these
We have
things.
to keep on pushing. Yeah.
Yes, we have to keep pushing.
Yeah.
And this once I spoke to a lady and she's a patient advocate, and she said, which still rings a bell in my head, doc. If there were no patients, doc, we would not be doctors. You'd be a doctor of what? You know,
Mm, mm,
if there were no sick people, there were no people with diabetes, hypertension, or the things that you love looking into,
mm,
what would we be doctors of? We'd
mm,
probably be involved maybe in research here, engineering,
mm,
like would be in other, in other fields. So them was trying to drive that was the fact that we need to listen to our clients and what they need,
mm,
and not just push things down their throat. We have said it is like this, it is like that. And you mentioned about oncology. There is an oncologist who actually mentioned that he usually receives clients, and when he explains, okay, we have found you with this cancer, etc., etc., and then he tells them this is how the treatment will go, da, 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 da. And then the client is like, okay, so is there another option to treating this cancer? And he asks, what do you mean by another option? I have told you these are there. No, and then the client will explain, and they're like, no, I am looking for, are there any foods I can eat, any herbs I can take, anything else that I can use instead of this or in combination with what you're trying to tell me? Because they only know of the adverse effects that can come with some of the treatment they're taking. So it's beautiful to actually see our population or our people being woke and realizing that there are other different ways to go about it, or there are ways you can go about it that actually gel with whatever already exists to have better outcomes, to have quality of life,
Yeah.
to have well-being later on in life. And Doc, I wanted to ask you something.
Mm.
You explained type 1 to type 5 diabetes, and even me, I am like, today I'm a student. Actually, giving because in his head he usually thinks Jackie knows everything. There, first. I wanted to ask in what exactly is insulin resistance? And number two, you mentioned something called DKA, diabetic ketoacidosis. I may understand that, but our listeners may not understand what exactly
Mm.
that is. And when you're taking care of these clients from type 1 to type 5, do they all undergo the same treatment? Is it different? How do you go about it?
Okay. For the sake of the layman, let's say, or the person who is not very used to the medical terms. So remember, we talked about type 1 being the type of diabetes where there is not enough insulin in the body. And
Yes.
insulin, it's actually not being produced. Let's just put it that way. It's minimal to zero insulin in the body. Insulin is the substance that gets the sugar from outside your body into the cell. We always talk about eat for energy, eat so that you get energy. Where does the energy come from? It comes from food. How is it broken down? So when you take your carbohydrates, your proteins, and your veggies, a lot of your veggies is probably minerals or amino acids and stuff. But a lot of your carbs will go down and be broken into sugars. So carbohydrates are just complex sugars. They're all broken down until they get to the final product, which is glucose. And then protein is basically going to be building block for your muscles a lot of the time, but it's not used for energy as much as carbohydrates are used. Fat is also used for energy, but the body prefers to use carbohydrates because it's a faster way of and more efficient way of getting the energy than breaking down fat. So if the body is given a choice, it can break down carbohydrates, it can break down fat, it can break down protein into energy, but it goes at okay, which one will take the least effort? The one that takes least
Mm,
carbs, then fat, then protein. So that means whenever you take your carbs, then that's the first thing that your body will go for as fuel. Now, it will be broken down into glucose. And then that glucose, now, the insulin, its work is to get that glucose from outside of the cell and then goes into the cell so that it can be used for energy. But when you have too much of the glucose, it stays around and then it's like, okay, I have nothing else to do. So it's converted into fat for extra. So basically, the body's like, what I need save, I'll use it for fuel for later. So think of fat as your stored fuel. That's why it's the second, because it's the stored fuel that's just waiting for when supplies are low, then the body can switch to fat for energy. Insulin is therefore very important for two things. It will ensure that you have enough energy in your body. And so the way the body is that it really wants your sugar level, because your sugar is what will give you energy, to be in a certain level. We call that homeostasis, where the body just wants things to be between a certain range. That's why your temperature is not 20 something. You want your
mm,
temperature 36.6 to 37.2. And that's where homeostasis takes place, because the body is the way God made us, if you believe in God, is that things are in a precise, orderly manner. So
yes.
ideally, the body wants your sugars to be between, when you wake up, it should be around 4 to 5. And then when you're doing your normal activities, it should not, technically, it shouldn't go above 10 for most
Mhm.
people.
Yes.
But then when you have diabetes, the sugars are high. So now the question is, why are they high? That's why now the type of diabetes comes in, because we are trying to figure out, why is this sugar high? It should not be
Mhm.
high. So in type 1, the problem is the insulin is not there to get that sugar from outside and take it into the cell. So that's why when you prick your nini, or if you have a CGM, whichever way you're testing your sugar, that's why your
Yes.
sugar is high, because it's just not entering the cell properly. There's no insulin to drive the cell.
Mm-hmm.
And that is called type 1 diabetes. And a lot of people with type 1 diabetes lose weight. One of their main concerns is weight loss. Why? Because the body can no longer use the carbs. Remember, we said insulin uses the carbs quickly. So it has to
Yes.
change to another way of getting energy. So it goes to fat. So what happens is the body starts using the fat, and then
Mm-hmm.
somebody keeps on getting thinner and thinner and thinner. Then it reaches a point, it even starts using the protein because that's a machine work. Why am I
Mm-hmm.
there?
Mm-hmm.
Because I need energy to survive. All my organs want something. Now,
Yeah.
insulin imekata. So
Yes.
these people with type 1 end up losing a lot of weight. They get, and the problem is that the byproducts of the breakdown of the fats and the protein leads to very dangerous toxins called ketones. Ketone bodies are not supposed to be in the system, but when you have breakdown of fats and protein like that, your ketone bodies accumulate in the system, and the body doesn't like ketone bodies. Ketone bodies are just, think of them as little, what, little byproducts, unwanted byproducts. Think of them that way. So they're just
Yes.
unwanted byproducts, and they just start accumulating in the body, and the body it's a toxin to the body. So now when
Yeah.
you get KA, that is now diabetic ketoacidosis, which means the ketone bodies have become so many until they have led to acidity in the body. So you have an acidotic body, a lot of acidity in the body, and it's not the acid in the stomach acid, it's acid in, so there's a lot of acid in your blood, and that acid needs to come out from somewhere. So you start breathing heavy, trying to clear it out from your lungs, because sometimes that helps. But usually the ketone bodies keep on accumulating, and it's something that can make somebody die because it
Mhm.
lowers your body pH. If you remember your
Mhm.
acid balance, whenever you have too much acid bodies, your pH goes down and the litmus paper turns.
Was turning red.
Umesahau.
Nimesahau, of course.
Red. Ah, wewe.
Si nimesema red. Nimejibu red tu. Sijasema.
So anyway, the body does not like acidity. And so when the body gets too much acidity, you will die unless you get insulin. So these people, unless they get insulin, they will die, period. For them, insulin is a lifesaver. It's not a choice. And that is why I'm a big advocate for type 1 patients getting insulin pumps, because it is not a choice for them. There's nothing lifestyle is going to do. There's nothing like, for them, it is their pancreas is dead, and without their pancreas they're not going to survive. It's a life or death
Yeah.
situation. Type 1s.
Mhm.
Now let's move to type 2s. Type 2s
Yes.
are people who, they've been taking sugar, honey. They've really been taking sugar, but not all of
Yeah.
them. Some of them don't necessarily take lots of sugar. It could just be carbs in general, complex carbs,
Yeah.
nduma, ngwashe. And by the way, when we are talking about carbs, we are talking about any carbs. There could, some of them are processed, some of them are unprocessed. So things, anything that's carbohydrate, it could be honey, it could be sugar itself, it could be donuts, it could be ngwashe, it could be, because some people have this conception that if you eat healthy food, so they say, me, I eat a lot of ngwashe, I eat a lot of nduma, I don't even know why I got diabetes. But my friend, nduma and ngwashe are carbs. So basically what happens is this: somebody has insulin resistance either because they have taken a lot of carbs and calories, and then now they became bigger and started gaining weight. And the reason they gain weight is because, remember, we said insulin's work is to give you energy and to keep your sugar between that level where the body wants, like between 5 and 8 or whatever.
Yes.
But then it becomes a point you've eaten like a whole, like you've eaten more than what your body needs. So what
Yes.
happens is the body decides, let me store this energy as fuel for next time. Inaweka fat.
Mm.
Then lunch ya kesho tena unakula more than you need. Haya, inaweka fat ingine. You continue doing that cumulatively, you keep on gaining weight slowly by slowly by
Yes.
slowly by
Yes.
slowly.
Yes.
Then now the problem is that the more weight you gain, the more insulin resistance. So the thing is, the more fat you have, the more the insulin doesn't work as well as it should. So now you now need much more insulin to make your sugar go down.
Mm.
So let's say when you are 50 kgs, okay, let's not use 50. Let's say when you are 60 kgs, you needed 2 units of insulin from your pancreas to make your sugar go down to 5. Then when you add 5 kgs, now you need 3 units of insulin from your pancreas. Then when you're 80 kgs, now you need 50 units. And it's the same pancreas still working. So what happens? The pancreas is trying, it's working and working. It's trying its best to keep up because it needs so much insulin now to try and bring your sugar down. Then it reaches
Yes.
a point now it can't keep up. So what happens is you have a lot of insulin in the system. It's a lot,
Mhm.
but your sugar is just not going down. And now your sugar starts going up because the pancreas capability to keep up with your insulin demands is not enough.
Yes.
So in this case, it is the weight and the fat that has led to this. But now I want to talk about a special group, which is my group, the PCOS group.
Yeah.
PCOS means polycystic ovarian syndrome. A lot of people think that the problem is at the ovary, but I want to tell you the problem is insulin resistance. The insulin resistance is inherent. Like you're born with the insulin resistance, unfortunately. And there's nothing much you can do about it because it's just there. So what happens is people with PCOS are inherently insulin resistant. And so what happens is the mechanism of getting the follicle out of the ovary is tampered with because of the insulin resistance.
Mm.
And then that leads to more and more hormonal issues because the problem, yes, is the insulin resistance, but it has led to an ovarian problem, which leads to a hormonal problem. And then the
Yeah.
cycle keeps on going and going because the more insulin resistance, the more insulin they have to produce, then the more fat they gain. And then it's just a cycle as well.
Mm.
So insulin resistance is all about insulin not being able to work well. It is there. In fact, it is there in plenty. Ukifanya insulin levels, they are high. So they are there,
Yes.
but they're just not working the way they should. So either it's because the body is inherently resistant, like people who have PCOS, or people who are taking steroids, or because drugs can give you insulin resistance. So that's why we were discussing about these people taking steroids, and we're like, do they know what they're doing to their body? Because
Mm-hmm.
you can actually take medication that give you diabetes. Some people get transplants and like kidney transplants, and then they have to go on this medicine to for immunosuppression, like tacrolimus.
Yes.
But
Yeah.
tacrolimus leads to diabetes through insulin resistance. So it's
Mm.
not a calorie thing. Sometimes it's the medication. So somebody
Yes.
on steroids or on tacrolimus, somebody who has PCOS, who is just born with insulin resistance.
Mm-hmm.
Sometimes it is related to pregnancy and gestational diabetes, as much as you might not like sometimes they put it in a class of its own, but it's inherently insulin resistance because of the hormones from the placenta. So the placenta inafanya tu insulin inakataa kufanya kazi. So now you
Mm-hmm.
have to give more insulin so that it does its work, and then that leads to diabetes because of the insulin resistance. So there are many factors. I know we always think of type 2 diabetes as, oh, which one is fat, therefore has diabetes, but it's not always the case.
Yes.
You can be lean and be insulin resistant. You can be pregnant and lean and be insulin resistant. You can just be on and they make you insulin resistant, and yet you've lived a very healthy life. So it can
Mm-hmm.
happen in homes. Yeah. So now the treatment for that, remember we said treatment for type 1 is insulin because for
Insulin.
them, it's a matter of, it's just there's no insulin. In this case, you
Yes.
have a lot of insulin. So the problem is not the insulin. The problem is you need something that will help you become more sensitive to insulin. A lot of people, I must say, who have insulin resistance get onto insulin because they are we are trying to bring their sugar down. We need to
Mm.
go to the root of the insulin resistance and ask
Yeah.
ourselves, okay, if this person is on this medicine that is making them resistant, can we change? If this person has gained a lot of weight, can they lose the weight? Because that will help them become more sensitive to insulin rather than keep
Mm.
on adding madawa, lose the weight, become more insulin sensitive. Some people, like the people who have PCOS, it's just metformin. They just need an agent that will help insulin work better. And when they
Mm-hmm.
get the metformin, the weight loss happens. Like in PCOS, that's why we give metformin because we are trying to make the body more sensitive to the insulin in the system. And
Mm.
it helps so many symptoms of PCOS just being on metformin. So personally, remember when I told you I finally accepted,
Yeah.
is that I
Yes.
finally went on metformin. I had
Mm,
been, as much as I was, I am a preacher of, try and nini, but I had tried lifestyle for the longest. And
yeah.
it's a point where my sugars, initially it worked, but it
Mm-hmm.
reached a point where my sugars started going high. And I accepted, I decided, you know what, it is what it is. I did not choose to get PCOS. I just have it and I accepted and I decided I'll start the metformin. And I lost 5 kgs just like that, just because I started
Mhm.
metformin. And my
Amazing.
blood cleared up and, like so many health benefits just from that one decision. So insulin resistance is a disease where we need to just figure out the root cause and try deal with the root cause. But if you
Mm-hmm.
don't deal with the root cause, a lot of times you will find yourself ending up with needing insulin. But
Yeah.
that was not necessarily what should have happened, if you get what I mean.
Mm-hmm.
Like, if we had
Yes.
noticed what to change earlier, we could change the trajectory of your disease just
Mm-hmm.
by doing certain measures to try and, yeah, and redirect the course of your insulin resistance.
I think in your next life, when you're choosing your career choices and paths,
Uh-huh.
look into teaching, education, imparting knowledge. You've explained, I'm just imagining there's a layman person listening, and
Mm.
I'd be like, "Yeah, wait, pause, take notes, and then come back and be like,
What's
because
your
it's very easy. Eh, yes. It's very easy to understand.
Oh, thank you, thank you.
Awesome. Now we move
I still
to
do a lot of
type
teaching though.
three.
I actually even have a
Mhm.
lecture. I'm doing a CME tomorrow, right here in Canada. Yeah. So
Nice.
I am a strong advocate in just, letting people will see the gift in you and
Yes.
put yourself out there. Don't underestimate the gifts that you have. And even if people, not everyone might like what it is that you do, keep doing it. If that's your vision and that's your purpose, imagine people
Mm.
will, you don't put make yourself small because you're trying to kind of fit in. If you're good at something, do it, and God will
Yeah.
just reward you, and people around you will notice what is genuine and like just genuinely coming from you as a talent. So yeah, that's what I would tell anyone out there who is trying to
Yeah.
get their foot.
Yeah.
Yeah.
At Eugene should do the amen. Amen.
Eugene, do you have the
Fine.
amen? Oh gosh, how funny.
Wait, okay. No. Oh my. All right, Doc. Uh-huh. So now we are doing type three, four, five. Mhm.
Yeah. So for type 3, a lot of times it just comes unawares. Remember, this is the one where it's pancreatitis, pancreatic cancer. It's something that's really beyond your control. There's very few people that I've met who ever said that, who had a warning for pancreatitis. I'm saying very few because some, especially alcohol induced, a lot
I
of
was
them
going
had
to
a
ask that.
warning. Because a lot of them they had like a warning kidogo, then they still went ahead and drank again and again. But I'm talking about just the pancreatitis that just comes. Whenever you meet somebody who has just pancreatitis out of the blue, and it can be very debilitating. Pancreatitis is a really, really bad and dangerous condition, and it can affect so many organs. It can cause ARDS, which is like lung failure. It can cause kidney failure. It can cause, so it's a really tough disease to come out from. And then later on, because the pancreas is the one which is responsible for insulin production, but also for digestive enzyme production, people end up with a lot of digestive issues, and then they also might end up with diabetes. So this diabetes is now known as type 3C diabetes.
Okay.
Previously, we kind of used to lump it with type 1 in a way because they're not producing enough insulin. But now, when somebody
Mm.
says type 3C, at least everybody will know, it's the pancreas. Okay, let's move on. So for these people, even just yesterday, I think I got a referral of somebody who has type 3C, and they want me their doctor wants me to consider them for an insulin pump, which by the way, here is free. Aki, ndio maana nakwambia Aki, where you are born matters, Jackie. Imagine having insulin pumps for free. For free.
Yeah.
For free. Do you know how many people have insulin pumps in Kenya? Like less than 100.
Very few. Yeah.
So
Those are
few.
very few.
So few. I think even less than 50. In the whole of Kenya, a country of
Those are the well-to-do,
well to do.
people
Because
that
kuweka
have.
pump ni 1 million. Kuweka 2. Then now the supplies, because you have to keep on adding insulin every 3 days. Then you have the tubing. Then you have the unini. It's like 50 Gs per month. Nobody's going to afford that. Like nobody,
No.
no average Kenyan can afford it. But yet so many need it. So anyway, yeah. The truth is, most of those people, it's just insulin that will work because it's kind of like a type 1. Because your issue is not resistance, it's just that you're not producing enough. So we can help a little bit with a few of the oral medications to just see if we can make someone more insulin sensitive. But at the end of the day, insulin is the best medication for them because they just need more insulin in their system. Then type 4, it depends. Like I told you, my grandfather, he's just on metformin and he's doing fine. So treat it as a type 2 pretty much because some might need oral medication. Some might just do well on lifestyle. And then some of them might need insulin. So it's out there. It can go either way. And then type 5, the malnutrition associated, a lot of them need insulin because the problem is the pancreas itself did not develop well because they had undernutrition in life. So a lot of them do better with insulin. And funny enough, they don't go into DKA because they have some insulin being produced. So they hardly go into DKA because there's just some amount of insulin there that's just enough to keep them out of acidosis, but their sugars are always high.
What I am learning from the conversation we are having is the fact that you see the way you do a meeting that has stakeholder engagement.
Yes, yes.
So we look at our clients from Dr. Hilda is there, Jackie is there, there is a gastro there because your client has pancreatitis or something. But we are all connected and we are all speaking one language. Because I have realized most of our clients sometimes they saw Hilda in Hurlingham, then Jackie saw them in Kikuyu, and then some other doctor saw them in Mombasa.
And then
And they
no connecting. Yes.
Yes, and no connecting dots, which now leaves our clients at a space of, okay, so between this, and this, what exactly am I meant to be doing? And they get lost and they don't know what it is that they're meant to be doing. And the reason why I say so is because what we've actually discussed, you brought about the concept of diet, you brought about the concept of exercise, you brought about the concept of poor nutrition, which now brings in, of course, you'll have some vitamins and mineral deficiency. And actually, from an evidence based perspective, there's some vitamins and mineral deficiencies that have been shown to be part of the trigger process of why some people end up with some of these diabetes, hypertension, and other chronic diseases. You brought about the concept of medication and how it can now trigger you into getting a condition, e.g., steroids, and also pill burden. You're on 1,000,001 medications, and they all end up causing one complication or another or affecting another because we never got to the root cause. You've also mentioned pregnancy, and I want all our pregnant ladies to know that please go for screening. Immediately you notice you have missed your periods, there's a way we also screen for sugars. There's a very simple test that is done for sugars. And sometimes when you don't go, you may not know what is wrong with you. And this is why we advocate for early screening, not just for us, the rest of the population, but for pregnant ladies, because it can bring complications to you as a person and to your babies, and even after you give birth. Other than the things that we've discussed all those things, pesticides, amongst all the other things, the concept of how mental health and chronic stress has now been shown to be a factor that is triggering these conditions. And you could prove me wrong, but I think when somebody is chronically stressed and you're chronically releasing cortisol, you're bound to end up with either one of diabetic, hypertensive, and develop other chronic conditions. Am I right or am I speaking my own gibberish?
No, you're absolutely right. Chronic stress has been shown to increase sugars. It's a known fact. And you yourself, Jackie, you said when you
Yes.
had chronic stress, you noticed changes in your body, right? When I was doing my residency, I had chronic stress, of course, and I noticed changes in my body. I
Yes.
gained a lot of weight. I had skin breakouts because my PCOS wasn't well controlled because of the stress and gaining weight. I have seen it in my patients. I am a strong advocate for using the continuous glucose monitoring. You know, that the thing that you put here, and then for 14 days, it tells you what your sugar is like. And a lot of times when it's high, like I had a patient, I think last week, her sugars just started going high and I was like, and she had been well controlled before that, and then just a week I could see that in that 1 week her sugars were high. She's eating the same thing, she's exercising the same way, there's nothing that has changed apart from the fact that she had some family stresses, and you can just see immediately she learned about it, the sugar just went up. Pressure, same story. Yeah, so cortisol is definitely a big factor in all this, and part of the management of diabetes, like even in the guidelines now, stress management and good sleep is one of the
Yes.
medications we give, because sleep is so important. We underestimate the importance of good sleep. Good sleep is medicine in diabetes. It's as good as a medicine, and I would say not just in diabetes, I think it's a medicine for so many more things, many more chronic illnesses, for your mental health. Sleep is very important, and then managing stress. So the thing about stress is I think that the what I usually tell my clients is it's normal to get stressed, but now it's about getting coping mechanisms for the stress, because life in itself, Jackie, is stress. You're never gonna just be there
Yes.
just going. And in fact, if you're in a place where you're not having a stressor in a manisha, you need to look and figure out what is there something. Why? You're pushing yourself. It means you're not pushing
That's
yourself.
true.
But
Enough. Huh?
enough, or stress could also come from outside areas. People have family issues, people have health issues, but then getting the coping mechanisms, and that's where mental health guidance comes in. And that's why a psychologist, a counselor, a psychiatrist, or just a mental health team is very important in the whole concept of diabetes care and in all chronic illnesses. Mental health is absolutely important, so I
Absolutely.
fully agree with you.
There's a client I had, and I think I even posted this in one of my stories. I submitted it as an article under KMA, Kenya Medical Association, where we had a client who it took about 2 to 3 years for them to accept to take medication. And now this pushes me to the concept of compliance, adherence, acceptance, denial, where you're finding somebody has sugars as high as 25, 20. You tell them, they look at you, they're like, eh. I remember that client had sugars of high as 14, 18, and then the blood pressure was in the ranges of 200 over 110 around. And I met this person during a medical camp. So I meet them and I tell them, the way we recorded, this one's neat. This is urgent. These are emergencies and urgencies. Your organs could be going into failure or complicated. You know, the person tells me, no, I'm very busy with work, so let me just rush this way, I'll come back. You know what? As a trustworthy Jackie I am, I told him it's okay. But I was always on the lookout waiting to see if I will spot this person. So day two comes, person has not yet come to me. I literally went and grabbed that person, come. I want to check again and see how you're doing today. Of course, I knew what the result would be because nothing has changed. Documented him, told the person, these are the sugars, these are the blood pressures. Yesterday was this, today is this. You need to start on medication. Person looks at me, is like, you write for me a prescription and go and buy it. That is what I do. So I wrote the prescription, but in addition, I also wrote some tests because I was like, no, this one, there's need for urgent help. And I also gave him a start medication just to help lower the blood pressure. And I talked about diet, lifestyle, mini, all these passionate things. I called the person after a few days, no response. I messaged, no response. 1 month, 2 months, 3 months in. Around 4, 5 months, the person responds and says, I took the medication that you wrote and I took it for 1 month and I saw the pressure was better and I stopped. Me, I almost fainted because in my head I was like, oh my God.
Mm.
Now this is a complication that you're bringing. You're so far away, I cannot even come and just keep monitoring you that closely. I literally need someone. Okay, I said, fine. So readherence, reassurance, recounseling. look here, you cannot just stop your medication, you have to be monitored. Did you do the test I asked you? No, I am busy, doc. Let me call you back. I have not done the test. But what I noticed all through this time is that his job is very stressful. And number two, what else ended up happening? He ended up getting into alcoholism. After he got the news of learning that there was pressure and diabetes, he now tipped over into alcoholism because it was a safe space for him and a comfort space. Because now, what are these things I'm being told? I'm 40 something. So it got to the point his wife had to look for me through his phone because now she was scared that my spouse is going to die.
Yeah.
The way I am seeing, my spouse is going to die. I can see somewhere you wrote medication was not taken, he stopped. I don't see him taking medication these days. Please look for him. This is somebody begging me to look for him. I'm like, so I look for the client. I'm like, I am short of coming to where you are. I can even take a car, and if your problem is finances, I will not charge you. My problem is the fact that you are going to complicate and more so even die. And the fact that these are high, it probably started a long time ago. But long and short is the fact that it took a journey, and I recommended even a counselor and a psychologist just to help with the person accepting and actually now realizing this is a problem because now there was also the problem of alcoholism. What are these habits we can change or alter with? Because you're stressed, as you said, how can we cope with this stress? We can meditate, we can pray, we can journal, we can socialize, we can go and laugh, you can go dancing, you can go exercise. There are different ways of managing stress. And so I told them those are the different routes you can take. And the counselor also recommended those things. Another thing that I realized I had done to complicate his life was putting him on an expensive antihypertensive. Yes. So it got to the point where his monthly expenses were so much. So he decided, let me stay without it because the expense is too much for my family. So I told him, okay, fine, you have other options. And that's now how he accepted to now be on now a more affordable antihypertensive as opposed to what I had given. And I realized now that was from a me perspective. I was also involved in poor adherence from the fact that I did not assess the situation or I did not learn more from the client just to be able to know, okay, this is too much for you from a financial perspective. Let me do a more affordable version that will also do the same job. So, in the spirit of speaking about compliance and adherence, what are some of the barriers, Doc, you've experienced? And I know maybe for you in that context, maybe you've not experienced barriers.
Yeah, they're
But,
there. They're still, trust me, what I realized is
yes, yes,
human beings are human beings, Jackie.
yes,
Doesn't
yes,
matter where, it doesn't matter whether they're from Canada or Kenya or you where. The only difference is just resource rich, resource limited. But then the rest, I would actually break it down as patient centered factors, system factors, and just others, like maybe the provider factors. So when it comes to provider factors, you've mentioned one of them, which is very important, is lack of, you see, like in your case, when you started the medication, you're like, I know this is good for you because you went maybe to a CME where uliambiwa kachai, ukaambiwa hii dawa ni dawa mzuri daktari. Then now that's the dawa you've been writing. I'm not saying that's what happened, but like you know how it is in the medical system. So you're like, this dawa, I know, I've heard about it. And juzi walitupeleka CMU wakatufunza vizuri, so let me write this. Then you forget that what about the long-term affordability? What about, like the indications? What about so there are many things you have to look at as a healthcare provider. So that's why it's always a journey of learning and relearning as healthcare providers. We cannot assume that paternalistic role that the older doctors used to have,
yes.
where they were always right and they were
Mhm.
always, what they say is law.
Yes.
That's how it used to be, Cindy. And some of them
Yeah,
were still.
that's true. That's very true.
And trust me, the way I approach my patients now is very different. And that's probably why across board, I get patients who tell me, hey, you're the first doctor who's actually listened. And I've heard that in Kenya and I've heard that here. So it means that's why I was telling you, patients want somebody who can listen Because when you listen, then
Yes.
you understand what their concerns are. You'll be able to tell, oh,
Mm.
this one, the concern is money. So whenever I write my medication, I should make sure I take care of that. Or this one, the
Yeah.
concern is depression. So I should not just write anything. Do you know beta blockers, for example, would worsen depression?
Mm.
But we write beta blockers for everybody. We don't remember that if you have a depressed patient, perhaps a beta blocker might not be the best choice. It might be indicated, but go slow on it, you know. So we have to always kind of build our knowledge so that we can do better for our patients and treat our patients with empathy the way we would want to be treated. I have seen healthcare providers who have locums in private sector and public sector.
Yeah.
The way they treat
Yeah.
patients in the private sector is very different from the way they treat the public ones, which breaks my heart.
Mm.
Just because somebody doesn't have money doesn't mean you should just, not listen to them or feel like they have nothing to, there's a certain way in which they are taken, which I think is wrong. So healthcare providers, we have a long way to go. We have to be better. We have to read. We have to, make ourselves more knowledgeable and look at the patient holistically. That's why what I love about you saying, like, you don't just look at their perspective of the disease. You want to look at what's behind the disease. Yeah, you want to dig deeper. So we all have to try to do that. Now,
Yeah.
the other thing that I've seen as a barrier is the patient factors. And patient factors, including culture, there are certain barriers, for example, here that the indigenous Canadians, we have indigenous Canadians, and then we have regular Canadians, and then we have Akina Sisi immigrants.
The immigrants.
So indigenous Canadians are like the indigenous Americans, and they have their own challenges. I can't get into them right now. So whenever I see a patient who is indigenous, I already know that there are certain challenges they have that other people don't have. And the way I would address their treatment is a bit different from others because it's like having a patient from where in our case, from like rural, there's a different culture. Like there's just something different with the way they approach everything, and so you
Yes.
also have to be respectful of that culture, but at the same time, make sure that you're giving them the best. Other patient related factors are things like the autonomy. I feel like there are many cases where the patient should have their own autonomy, but because they are not the main financier of their issues, they end up not, how do I put it? Like it's kind of they're put on the back seat because they are not the ones who are providing the finances for the particular journey. And that
Uh-huh.
that changes everything because the patient is supposed to be your patient, but sometimes you're ending up dealing with the patient's mother or the patient's husband or the patient's something rather than
Yes.
putting the patient first. It's both a healthcare provider and a patient factor, I think, put together because we have to have that intuition to kind of tell when there's something like that. But also on the patient side, we have to uplift the patient to understand that you are still the driver of your journey as long as your GCS is 15, yeah, as long as you're competent, you should be the driver of your journey, even
Yes.
though you're not maybe the one with the money or you're not the one. Speak for yourself, speak out your problems, speak out. We need to our patients, I think, need to learn how to be more confident to speak about their issues themselves.
Yes.
I saw
Yes.
a lot of challenges in that aspect, especially in Kenya. The other patient factor that I can think of course, is finances. That's just, yeah, and that's why we
Mm.
have to be like, how many patients do we know who would benefit from Ozempic? So many, so many. Anybody who has kidney disease and diabetes, anybody who is obese and has diabetes, anybody who, so many people have indications, but how many can
Yeah.
really afford? That's so the finances plays a big role. And then for some, it's also just their job. There are people who have type 1 diabetes who've told me, I don't want people to know. So I don't want to prescribe something that I have to inject myself like in front of everybody or whatnot. Like sometimes I have to kind of understand where the patient is coming from, what their preference are, and then their
Uh,
mental health at that time. So there's many
mm.
things that go into it. But I think for me, I would say The thing that I use mostly in the diabetes space is just trying to make the patient understand that they are the ones in the driver's seat. It's not me. I'm just helping them. I'm like the Google Maps, helping
Mm-hmm.
direct, but they are
Yes.
the ones driving. They are the ones
Yeah.
who have to take care of their body. It doesn't
Yes.
matter what their who is paying the bill or who is doing what or whatnot. As long as they are competent, they should have that confidence. Whether they
Yeah.
are on injectable insulin, insulin pump, oral medication, lifestyle, it doesn't matter. They need to understand that the choice you have control over this. Don't leave that control to somebody else, as
Mm.
many. And then now the healthcare system factors, which are so many. So many, we can't even get into them. But
I know.
that's how I look at those barriers and challenges.
Mm. Mm.
There's a lot that you can do with each of them. I think it's a whole CME for itself.
Yes.
But I think as
Yes.
healthcare providers, ours is to be cognizant because sometimes we have a bias and we don't know we have a bias. Like you might just see somebody who looks, then you're like, this one won't be able to afford that medicine. So you decide you're not going to
Yes.
tell them about it because after all,
They
or
can't
if
afford
I start telling
it.
them about gym, how will they even do? You know, I will say, now
Yeah.
if I tell them exercise, this one doesn't. So
Mm.
let's not have that bias as healthcare providers, and let's be intuitive enough to kind of know the barriers our system has and then the barriers that our patients have. And sometimes we help the system barriers. Like one of the things that I used to encourage my patients is get insurance, get NHIF. I left when it
Mhm.
was NHIF. I don't know what SHA did because every day I say SHA, SHA. All I know is that not everyone likes it. But empowering them to get insurance is very
Yeah.
important, and understanding that, especially in our setup, that that insurance is very important because it can help you get screening, and if you get complications, it can help you deal with the complications, and you can get access to dialysis or access to a cardiac
Mm.
cath,
Mm.
just because of
Mm.
the insurance. So it's very important for us to be the patient advocate and kind of guide them in that scenario. Yeah.
Yeah.
Mm.
And I think in the light of ensuring that our patients and clients are able to afford the healthcare, this is
Mm.
where you mentioned when you are here about the NHIF, and if people can be able to enroll into SHA, but
Mm.
it also has to be a system that is working. And I say
Yeah.
so, you know how private insurance can be a bit on the higher side. When we are having people in Kenya who are actually living on day-to-day means, like
Mm.
ile umepata leo ndio hiyo ndio anatumia hiyo siku na imeisha, tunaendea the next one imeisha, yeah. So we've gotten to the point where somebody asks you like you're teaching me how to save. What are you teaching me about? I don't even have a dollar or two to save, right? But if we have a system that is actually working, and which I think can work as long as you said, some things are just put into place, we would actually have a system that
Mm.
works. And most of us would actually end up being on that system. And these other
Yeah.
ones would be,
Yeah. Yeah. And the thing about Kenya, to be honest, I still think Kenya has the most brilliant people I've ever met. And I'm in Canada. But I honestly think Kenyans are so innovative, so creative. Like NHIF was to go to the next level. There was expertise to take it to the next level. This whole things were just because people wanted cuts out of everything. But anyway, the system has to work for many things to happen. And the problem is that it creates a lot of frustration for healthcare providers. Personally, I won't lie. One of the reasons I left Kenya was I was so frustrated with the process. I was so frustrated. And I had worked in public sector. I actually prefer working in a public health sector than private because I
yes,
feel more fulfilled. But it was so difficult because you're seeing this person who needs an echocardiogram and we'll never get it. They have mamas from here to
yes,
never
yes,
get an echo.
yeah,
A
yeah,
person who needs dialysis, no access. A person who is on dialysis and then the catheter fell, but they only had cover for that one catheter. So now they don't have money for another catheter. So now I was like, what is this? It reached a point where I was like, you know what? I just can't deal with this. So for my own mental health, I had to step out.
yes,
I honestly that
yeah,
was one of my like drivers out. And
mm,
so the system has to work better in order to retain healthcare providers who are truly passionate and ready to work and ready to help the people, you know. But we can't lose hope. I think there's still a chance. There's still hope that because we have all the people that it takes for the system to work. So it's a matter of us just taking that step forward and saying we're in it, we're in this, and things have to change. And I'm looking forward to that day when things will
Yeah.
change. Yeah.
I know. We are always hopeful. But you know what? I usually say, as long as we are also continuing to speak this voice of
Yes.
prevention, prevention, prevention,
Mm.
the more we are speaking about it, the more people are learning about it, the more people are questioning, the more people are saying no
Yeah.
to certain things. We
To
want
certain
things
things.
this way,
Hmm. Yeah.
which
Like
I
the
really
food.
love. And
Mm.
yes, even such foods, because now we even get to the point where people are like, so you're telling me to eat nutritious foods. Where am I meant to get those things? All you're saying is
Mm.
chemical, blah, blah, blah. And I'm like, even though you live in an apartment, you can actually use your balcony as a source of
Yes, as
planting
a
stuff.
source of, and the tire system. You know that tire thing? My mother had one
Yes,
where you put boga and then you put
yes,
another smaller tire and you put nini nini.
yes,
Yeah. So
yes.
it's possible.
Yes,
You're right. It's
it's
very
very possible. It's just that sometimes we see as though, oh, I need money to go and buy CG what. Jana, I was seeing somebody who put,
mm,
and I was like, I'm going to try this and see if it works. They took the onion, both the spring onions and the bulb onion.
mm,
So the spring onion, they cut the top part, so they remain with just the stem, and then they put it in water and they put it next to a window, so it starts sprouting and growing. So that is how they get their onions, and then the same to the bulb onion. Because I will try this one because I'm a trier of things just to see. So when we say sometimes we really also the fact that we've gotten to the point where we are saying we have to take things into our own hands as well,
yeah.
because if the system is not working and
Yes.
seemingly maybe they make us the CS and the PS of health and then we'll make systems work.
Amen, sister.
Yeah. But if even though the systems are not working yet, we also have a role to play on how we are going about these things. Yeah.
Exactly. Yeah.
And you mentioned something very interesting, Doc, when you're discussing about how obesity and your weight can actually contribute to you getting diabetes. Ooh-wee. And then you mentioned something that has been a hot topic in this country, Ozempic. What was the Ozempic?
Ah,
Kuna Bunjaro, and I know you know other things.
so, yes.
Yes.
All
You
those.
mentioned how
Those
they
are
can
the
boost,
ones that are hot cake, but there are others, by the way. It's just
of
that hizo
course.
ndio zilikuja zikachukua the world by storm. The whole world,
Yes.
not just there.
Yes.
Hata hapa, every week I get
Eh,
somebody asking me, daktari, please, uniandikie kwa tu ile.
eh.
Niandikie.
Hebu sasa tuambie
Mm,
tuchukue ama tusichukue ama how do we go about it, because I have gotten
mm,
enough. There's actually a client who came to me and she was like, oh, so me, I've been this way all my life and I'm thinking of taking Ozempic.
mm,
And I was like, I assessed her and she had she didn't know that she was actually hypertensive to start with. And I was like,
mm,
and she's very young. She's less than, she's in her mid 20s.
mm.
And I was like, hold up. There are some things we need to address before we even start thinking we are going to Ozempic. Your blood pressure is off, you smoke, you do shisha, you're drinking alcohol,
Yeah.
your diet is already off, and you want to just lose weight. So I feel like this for you is a quick fix, and there
Mm.
are other things that you need to work on before you even decide. So, Doc, ebu fafanua
Eh,
kinagaubaga, this Ozempic business.
Sasa, hey. So Ozempic, I can come with some good data because I have treated hundreds of patients now with Ozempic.
Mhm.
So I know how it works. I have treated very many patients with it. And I started when I was in Kenya. And then when I came here, I came to a system that actually pays for its people. Depending on whether they fit a certain criteria, the government pays for Ozempic for you.
Yeah, yeah.
So let me first say, before we even move to Ozempic, that
Mhm.
weight loss has always been a big topic. And I guess that's why when Ozempic came, the discussion even moved from its intended issue, which was diabetes. See, it was
Yes.
intended for diabetes. That's where it was
Yes.
studied. That's where majority of the studies were done. It reminds me of Viagra. You know, Viagra
Yeah.
was for pulmonary hypertension. Like
Yes.
people were just they were just in a trial for
Mm.
pulmonary hypertension, and then they went and told the investigators, "Eh, hiyo dawa mlitupea lakini
Mm.
do some things." And then suddenly, because the money is in that other thing, that's where it went.
Yes.
And so Ozempic gives me the same vibes because it was initially just meant to be a diabetes medicine, and now things just changed. So weight loss is a big topic. When it comes to things like weight loss strategies, let me put them as a bunch first before breaking into Ozempic. Is it's important to know the who, the why, the what's, and the how, right? So with the who, it's first of all, like you said, who is this patient in front of me? You have a mid-20s patient whose lifestyle is clearly, there are many things that they can do with their lifestyle.
Yeah.
And they don't have any complications yet, but they are at high risk because they're already hypertensive in their mid-20s. So if they don't do something now, things will not be better in the future. So they have to do
Mm.
something. So that's the who. There's another who. The other who could be somebody with diabetes and kidney disease. There's another who is just someone who is obese. That's just it. They have nothing else. They don't have hypertension. They have nothing else. But they have started on their lifestyle journey, but they're not seeing any changes. There's another who could be somebody who is hypertensive, maybe diabetic, is not obese, but is just afraid that they have these conditions and they're worried that later on things are going to be difficult for them. So they come and ask, will this medication help, even though I'm not obese? There's another who is just somebody who wants to fit in their wedding dress in 3 months. So you see, like there, it's a whole, and
Mm.
I've seen all these, the ones I'm saying, I've seen all of them.
Yes.
That's why the who matters. Then after the who, it's the why. So why is it that you want to take it? For some, like that one who wants to fit in a wedding dress, they just want that short-term goal. I want to lose 10 kgs, then fit in my dress. Then after that, I don't care. The diabetes with kidney disease, for them, it's their life. Like Ozempic, the GLP-1s or Mounjaro, Ozempic, they've been found to be very beneficial for people with kidney disease and heart disease. So this is somebody who has a solid indication. They have diabetes and they have kidney disease. That's a really good indication, especially if they are obese for Ozempic. Then you have um, the patient like yours who
Mm.
the lifestyle is crazy. They've not started doing anything about it, but they want a quick fix. And
Yeah.
then you have that hypertensive diabetic person who is not overweight, but just wants to know, will this be beneficial? Then you just have that obese person who's just obese and
Mm.
wants to,
Mm.
but has been trying. So then comes the how. So, and that's now our role, because I think our role is to guide the patient on the how. They come to you because they want to understand, is Ozempic going to be my quick fix or is there something else I can do? And that's why you, Jackie, when you looked at that 25-year-old, you're like, you still have so many things that you can do to fix your life. Ozempic is not the answer.
Yeah. Yeah.
You need to figure out, like, how am I going to get better? How can I start exercising? How can I quit smoking? How can I quit? There are many things you need to do before we even start considering you for that. And then now the
Mm.
next one, the what? What is your target? Is it that you're just targeting weight loss? Are you targeting better renal and cardiac protection? Because that's a whole different ballgame. Are you targeting weight loss to reverse prediabetes, for example? And I can tell you for a fact that the what influences the how, right? Because the what is the targets that we know as the healthcare professional. We're like, yes, the
Mm.
patient's target is to lose weight, but what is the target that I think the patient should have? In your case, your patient's target should be live a healthier lifestyle, stop smoking,
Yeah.
start exercising. Those are the targets that you think the patient should have, although that's not what they think
Mm.
they should have. But
They
you are
should
the
have. Yeah.
you are the person who gives the advice. That's why you're there. Otherwise, everybody would
Yeah.
be on there. So
That's
I,
true.
I I feel like our role somehow is to be gatekeepers of Ozempic. Is there a problem if someone just decides that they just want to lose 5 kgs and look good for their wedding dress? There's no problem. But do you really understand what Ozempic is and how it works and that it has side effects. We are not dishing out sweets. We are not dishing out. People forget that just because you look good doesn't mean. By the way, Ozempic can trigger pancreatitis. It can trigger
Mhm.
retinopathy. It can trigger, there are many things that it can do. A lot of GI issues. A lot of people come and they can't even tolerate it. People who have a history of medullary thyroid cancer can't take it. So we have to kind of be responsible with the way people are doing it. I know right now as we speak, people are getting Ozempic in spas in Kenya. Unaenda tu kwa
Yes,
spa
yes,
na unadungwa.
yes,
So
yes,
to be honest, the system has already lost the battle. We are not gonna gatekeep because the system has it's you can only gatekeep if the system is so strong that truly nobody can get that Ozempic unless the doctor has prescribed. So, like here, for
yes.
example, all medications, because Canada has a very strict system, so all medications you have to get a prescription. You can't just walk into the Nini and get Ozempic. No, prescription
Mhm.
which are traced. There's a doctor who was penalized because he started selling Ozempic because Ozempic is cheaper in Canada than it is in the US.
Mhm.
Daktari akaona ile pesa anaweza tengeneza hapa. Can you imagine?
Eh,
Ozempic is, let's say, 30K here, then you sell it on the
yes,
other side for like 100 Gs. Hey, he made money. He made money.
money, yes.
And then the system caught up with him. So at the
Yeah.
end of the day, if you have a system that works, it will always be able to kind of, figure things out. That's why I say that gatekeeping. But now, when we are talking about Kenya, unfortunately, gatekeeping hakuna. Dawa ziko, and people will use them. So now the thing is, how do we help people make better
Mm.
choices and to understand that this drug is not a quick fix, and you don't just use it because you want to. You need to understand why are you using this, and the problem with things like Ozempic is that if you don't change your lifestyle, for example, if you're the 25-year-old,
Yeah.
you can use the Ozempic and lose weight because she'll get it at a spa anyway. Hata ukimkataza, maybe hata ashaanza by the way as we speak. That's
Mm.
just but
Anyway, that's the honest truth.
yeah. So you have to sometimes me, I'm a pragmatic person. So me, I usually don't look at the world as roses and nini. I usually look at it as the way venye iko tu ndio
Yes.
ninaiona. So she probably is probably on it. She came to you and she saw you. So she went to somebody else who was prescribed because and influencers are there selling the drug like nonsense. So now it's us to kind of help them understand how to do it and also to understand that if you don't change your lifestyle, because you're not going to afford this drug forever, at some point you'll have to stop it. And if you have not changed your lifestyle, by the time you're stopping, you'll just gain the weight back and you'll be back
Yeah.
to square. So I think there are many gaps that could be like filled. The PPB, Pharmacy and Poisons Board, has to be more
Yeah.
proactive in terms of who is dispensing the Ozempic and try to figure out where people are getting the so-called illegal ones. And then apart from that, now our role is to educate the public to be aware, to know, fine, you got it from the spa, but just know that these are the side effects. And just know that, yes, you might get it now, but if you don't fix your lifestyle, things will not change. And then also be the ones to guide the right patients to get the drug. I think the
Mhm.
thing that I don't like is the fact that the people who actually need it don't get it. So
Yes.
the people who have that diabetes with obesity, type 2 diabetes with obesity, the ones who I was saying have insulin resistance and we can avoid being on insulin if they lose weight. Those are the ones who need that drug because if you give them Ozempic and they lose that 20 kgs, that 30 kgs, then the insulin resistance goes down. Then they don't have to be on insulin. They can just stay
Mm.
on oral medications and that's a win for them as long as they are doing it and also changing their lifestyle.
Mm.
um, then the right patients should get it. The people who actually need it should get access. The problem is the cost and all that. But
Mm.
at the end of the day, I think it is a good drug. I've used it on hundreds of people. Only very few, I think only one, I think got pancreatitis. No, maybe 3 or 4 got pancreatitis. And once you notice that pancreatitis comes in, of course, you stop. Personally, I don't. Once somebody gets pancreatitis, I'm out. Like, I'm not going to use it again. I know some
Mm.
people usually say you could use a lower dose, but I don't. Retinopathy. So make sure, like, if someone is diabetic, make sure they're getting their yearly annual screening of their eyes. Yeah, keep up abreast of those complications. GI complications, they will tell you because, diarrhea, bloating, blah, blah, blah. Sometimes they're not even able to. I had a patient who just could not tolerate, like the symptoms were so bad, they had to come off of it. And remember, here it's free. So it's not like the
Mhm.
money, but they just could not tolerate it. And we just had to say, you know what, we tried. Yeah. So I think our role is to make sure that the right person gets it. The role of the system is to help streamline who sells it, but then the patients should be aware what the potential complications and risks are. But I think the most important thing, in my opinion, is for the patients to know that Ozempic is not the answer. Lifestyle is the answer. Ozempic is just there. It's like any other medication, but you have to change your life. You have to decide to exercise, eat less, eat healthier. Those are the most important things. And actually, I want to give a big shout out to all those patients who have managed to do that without Ozempic and without any help. Like, there are so many people out there who decided, I am changing my life, and they did it without medications, without anything. And to me, I think that is the best way to go, because you're giving yourself now a life that is a skill that you have now gained, and you're going to use it for the rest of your life, as opposed to Ozempic, which will come for a few months, then it will go, then you gain the weight because you never changed what brought you there in the first place. So that's my take.
I feel like we should just end it there. You see the way it has ended on a high note. Guys are like, okay, oh, so like you've gotten to the point where Ozempic is a quick fix for some people because you go off of it, you do not have the resources to get it again, your weight will just
Yeah.
come back. And the fact that lifestyle is where you should put your eyes on and focus on, because if it is something that you can actually be able to change, then why
Yeah.
not? Because it's
Why
something
not?
that you can be able to sustain and continue with. And I know, and just as we're coming to the tail end, I know people usually think that lifestyle changes are expensive,
Yeah.
and I am here to demystify that myth. Lifestyle changes are not expensive. You have options. For
Yeah.
example, when it comes to something like exercise, because that is one of the things we always talk about, it doesn't have to be the gym. You can walk, you can run, depending on if you have other conditions. You can cycle, you can go for a swim, you can do yoga, you can do Pilates, as in you have a whole variety of things that you can do. You can even do that home gym. You know the one where you make stones
Them
and,
away on
and
the sides.
where
Yes.
you can do such things at home. You also have children. You can actually try and exercise with your kids at home. There's some exercise, your kids are like around when they're small, 9, 10, 12, 17 kgs. You can use them as a way of. So sometimes, and even water bottles at home where you have a 1 liter, 2 liter, 5 liter, 10 liter. So you just gradually go increasing. From a food perspective, people say, "I lakini doc, sijui you're telling me to eat asparagus." No, asparagus is not for everyone because it's even not even available in Kenya. We have our readily available kienyeji green. We have githeri without potatoes. We just put in your kitunguu, your nyanya. We have what is this fish that is tiny like this?
Omena.
We have buta and bufula. As in, there are things that we can also be that are available readily in our context and we can afford, as opposed to moving towards the things that are, and you mentioned them, those carbohydrates that are just like they're just a ticking time bomb. And we have actually put that in our systems that it's cheaper to buy bread, it's cheaper to buy mandazi for the morning breakfast where you're doing for you and your kids, as opposed to say you're buying something like you're eating like the githeri you ate last night, you're eating it in the morning, for example, right? Or the whatever food you ate last night, you're eating that omena with kidogo nini in the morning. So we just have to change some of these things into better practices, but more so we just keep educating our population, because the more they know, the more they teach somebody else, a neighbor, someone else who's nearby them. And the fact that it's doable, it's not difficult. Lifestyle changes are doable, and it is very possible to actually remain consistent with them. And as Doc said, stress will always be there. You started going to the gym and then ukashindwa because there were financial issues, or you're tired, or you're busy with work or something. There is a way to also manage that. And I want to tell our clients when I don't know, Doc, if you ever get those clients where they've disappeared, like they're going through, for lack of a better word, and they were seeing you and they were on a certain medication, but then they are in that hole and they put themselves in a state of, I can't be able to afford this, or I'm not in the space to talk, I don't want to see people, I don't want this, I don't want that. Please reach out to us. Like we are the one people who we can't judge you. We don't know you like that. So there's no way we can actually judge you and decide this person is like this because of this and that, or this person is this type. No, we don't know you like that. We just know you from a client or a patient doctor kind of relationship. So we are bound to easily understand you. And we have a bigger scope of understanding you. We have more knowledge, we have more information to be able to help you out. So I really appreciate you, Doc, for the knowledge and impact that you've shared with us today, because I know there's going to be a lot of impact, and this is just the beginning. And as we finish up, I want you to give us your parting shot when it comes to prevention and management of diabetes. What do you think would be your parting shot? What would be your call to action for our population, both here, everywhere? Okay.
Mine is to remind each and every one of us that you are the driver of the bus. Don't let that driver's seat go to anyone else. I know there are certain situations or circumstances that might take you off the driver's seat for a while, but you are in charge of your health. So take charge.
Amazing, Doc. Thank you so much. I think Eugene is forgetting to put the things for clapping.
Hey, you did a big clap for me. Yeah.
Oh my God. And as we finish off, I would like to say there's nothing as difficult, complicated, financially, emotionally, psychologically, mentally, as dealing with a chronic condition that has become complicated. It can deplete you in a myriad of ways. So always remember prevention is better than cure, and you have doctors who are knowledgeable and who are ready to help you. So please do not stay silent and be bothered by something that can actually be helped. And on that note, Doc, what are your handles on social media as we part, where
Yeah.
people can find you, all those things?
So I mean, I'm still going through a metamorphosis because I moved from Kenya to Canada. So on Instagram, I am Dr. Hilda Nabiswa _ CA. I might change my name. I'm thinking. I'm trying to feel different names. And then on YouTube, I'm diabetes doc _ KE. And on Twitter, I am also diabetes doc _ KE. So, been a pleasure. Thank you so much, Jackie. Thanks, Eugene, in the background. Thanks for inviting me.
You're most welcome, and bye. Have a lovely evening.
Thank you. You too. It's 11 now. I need to go and make my hair. So, yeah.
I'm going
Okay.
to make my hair as well, and it is 6
Oh,
p.m.
really? Ah, okay.
Yeah, it has to be made.
Good for you. Thanks, Eugene.
Thank
Wacha
you,
mi
Eugene.
nitoroke sasa. My hairstylist
Yeah.
will be mad at me. Bye.